Hello, and welcome to today's Clinical Care Options Neuroscience podcast. Halting Hallucinations, a discussion of management strategies for Parkinson's disease psychosis. I'm your host, Dr. Lisa Phipps. Today's episode features a conversation on Parkinson's disease psychosis between two expert clinicians, Dr. Marwan Sabbagh, a professor of neurology in the Division of Alzheimer's and Memory Disorders at the Barrow Neurological Institute in Phoenix, Arizona, and Dr. Marta San Luciano, an attending neurologist in the Movement Disorders and Neuromodulation Center at the University of California, San Francisco Medical Center. They will be discussing Parkinson's disease psychosis from diagnosis to management, sharing insights from their clinical practice and real-world experiences. This episode is part of a larger educational program titled Diagnosis and Management of Parkinson's Disease Dementia. For more information on Drs. Sabbagh and San Luciano, along with a link to the complete program, including an on-demand webcast presentation, please visit the show notes for this episode. Now let's get started and hear what Dr. Sabbagh and San Luciano have to say.
We're going to start out by talking about Parkinson's disease psychosis. And Dr. San Luciano, you, I'm sure, see this as a common complication in your medical practice of patients. Can you describe what is the PD psychosis and give me some of the prevalence data?
Yes, thank you. Symptoms of psychosis, including hallucinations, like seeing or hearing things that are not really there, and delusions, having beliefs, that are not true. For example, like the police is after them, are common in patients with Parkinson's disease. I would say, up to 70 or even more % of patients as the disease progresses, are fairly common. Now, it occurs typically not at the beginning of the illness, but usually within years into the disease, anywhere between 5 and 15 years, even later, predominantly in people who start with the disease later in life.
And so is it more common to see hallucinations, delusions, both? Is that a tip-off on the visual hallucinations on synucleinopathy or Lewy body, or what's the thoughts there?
Yes, visual hallucinations are quite common, and they tend to be one of the earliest signs of Parkinson's disease psychosis, or even Parkinson's disease dementia. One of the earliest signs. It could also appear as side effects from medications. All dopaminergic medicines that we use in Parkinson's disease have potential of causing visual hallucinations. Again, people tend to see things, rather than hear voices or have other sensory experience. And visual hallucinations are common, for other synucleinopathies, like Parkinson's disease, dementia with Lewy bodies, of course, and far less common in other diseases in which cognitive symptoms are not prominent.
And so would we expect when the cognitive symptoms occur, would the neuropsychiatric features increase? So is that a comorbid condition of the PDD, or is it you can see it at any phase along the way?
Psychosis can happen along the disease course, although it's highly unusual early in the disease, especially in younger individuals younger than 70, younger than 60. It certainly can accompany the cognitive decline part of Parkinson's disease dementia, but not necessarily. However, commonly co-occur at that point. But psychosis can happen in the absence of cognitive impairment in patients with Parkinson's disease. I have to say, that I rarely ever see Parkinson's disease psychosis in the absence of any cognitive impairment.
And I saw the statistic that in time, 40% will develop PDP. That seems very high. I remember seeing Dag Arslan once said that, we used to underestimate the amount of PDD going on, and now it's up to 75% of PDD. Are we seeing increases in prevalence of PDP as well, or is it recognized more, or what's the thought there?
Yeah, I think I agree in which, we're getting better in the treatment of the motor symptoms. Patients are living longer and they're having the disease for longer. And that is a risk factor for the development of cognitive impairment and certainly Parkinson's disease dementia or other dementias that can appear, the comorbid, pathology of Alzheimer's and Parkinson's disease and dementia. I would say that in regards to psychosis, it is also more recognized now. I think we're diagnosing it better now. we're particularly asking about it more, and patients are getting a little bit more open. So I think both, there's increased recognition. There is, the fact that, as people live long, indeed, the symptoms are going to happen, more often. I don't think per se, that there is a true then increase in the prevalence, because of other factors.
Now, you were kind of mentioning before some of the risk factors for development of PD psychosis. Can you kind of elucidate those again, please?
Yes, I think advancing age is always a risk factor, for PD psychosis as well as for PD dementia. And together with that is disease duration. The longer one has had Parkinson's disease, the higher the likelihood that the symptoms may happen. The use of medications to treat Parkinson's disease, but particularly some of them, dopamine agonists, can have hallucinations and delusions as side effects, or may uncover a Parkinson's disease psychosis that may be subclinical or near the surface. But also carbidopa, levodopa, the ones, with fewest, side effects, can trigger psychotic symptoms. The presence of REM sleep behavior disorder, can be a risk factor as well, for PD psychosis, but it's also pretty prevalent. And then obviously, prior history, this is not talked about too much, but prior history of psychiatric illnesses, with pre-existing, psychotic features, will make it more likely that people will have symptoms in the context of Parkinson's disease, or maybe decompensated with the Parkinson's disease medications.
Can you speculate the mechanism? So if I give a dopamine agonist, I'm hitting the D1 and D2 targets. Just mechanistically, how would that trigger hallucination?
That is a good question. And I'm not sure if I can give a very thorough answer. But I think in the same way that the dopamine agonists, who stimulate primarily D2 receptors, and particular stimulation of those receptors are thought to be behind, the neuropsychiatric features of those drugs. And they share some commonality, with what happens in PD psychosis.
If a patient comes in with PD psychosis, kind of what is your approach in terms of diagnosis, management, things like that?
The very first thing, to do is to eliminate other potential causes, that may be, before landing in calling Parkinson's disease psychosis. It is common to develop symptoms of delirium that may include hallucinations and delusions in the context of infections, particularly urinary tract infections or upper respiratory infections, So an infectious workup, would be first. Then a thorough review of medications. Medications may have been added, doses may have been increased, and that may need to be revised. So if possible, some of the dopaminergic medications, they can be reduced or some could be eliminated, like dopamine agonists, like anticholinergic medications. Those are common. Sometimes they're used, for urinary symptoms that are also common in Parkinson's disease that may trigger some of these symptoms. And then if need be, and if there are concerns that it's not only psychosis, but there may be cognitive impairment, we may pursue more in detail neuropsychological testing, to delve farther into whether cognitive decline may be a part of the syndrome. Again, so laboratory tests, urinalysis, chest X-rays, and a thorough exam and interview, of course.
I have to tell you, I have diagnosed more UTIs than I could ever imagine as a dementia doctor. I didn't think I was going to diagnose so many UTIs as a neurologist, but
that's a valid point. I do that often too.
Yeah. And there's a lot of debate on whether DLB and PDD are a different construct or the same construct. What are your thoughts about that?
The eternal dilemma. My opinion has always been that it is part of the same spectrum of, if a patient with, pretty classical garden variety Parkinson's disease, lives, for many years, decades, the majority of those patients are going to eventually meet criteria for Parkinson's disease dementia. That Parkinson's disease dementia may look clinically very similar to somebody with DLB, with the only difference, that the timing of the onset of the motor symptoms and the cognitive symptoms. Pathologically, they look similar. Now, what is it different that sparks, that pathology in a widespread manner versus some more localized and slowly progressing? That I don't know. But I think they're similar enough that we can consider them two extremes of the same spectrum. And there are patients, especially older patients, who may start with Parkinson's disease and may have very subtle cognitive changes that may not meet criteria, but within 3 years, they do And so I think those are the ones that are sort of in between, as opposed to the more classic, patient who starts in the mid-50s and very little to no cognitive impairment. And it's only when they reach age 75, and now they've had it for 20, 25 years, when they have the motor symptoms.
So do you use any screening tools or quantification tools like a neuropsychiatric inventory, or to quantify the severity or morbidity of the Parkinson's related psychosis? There's the Cohen-Mansfield. There are a lot of dementia ones. I don't know if you do that in the Parkinson's side. We typically, for clinical care, we do not use validated tools for psychosis. We Right.
will do for cognitive impairment in the bedside, maybe just a MOCA, one-drug cognitive assessment, and then patients who we are considering for surgery, they will have a big battery of neuropsychological testing with a neuropsychologist. But we don't use particular validating screening tools. We do ask in very detail about this particular symptoms, not only the patient but a caregiver, somebody who knows the patient really well. And we'll follow the symptoms closely. Have you found those scales, or did you ever use them?
Yeah, I mean, I'm aware of them, but I don't, like you, in routine practice, I don't use them. In clinical trials, we use them a lot, but not in routine practice. I mean, like you, I try to, I'm sure, I try to be efficient in my clinic, and those scales take time to do, and quantification. Mm-hmm. Usually in a few questions, you can get an answer on to whether they have some psychosis delivering. And I don't quantify it. I don't talk about this, burden or disability of it, but I capture it as in part of my interview. But let's move on to talk about the treatment of PD psychosis. And the first thing to think about is it reversible, preventable? Any thoughts about that?
I think in some circumstances, it could be reversible, particularly those that are clearly associated with having a concomitant infection or clearly related to a medication use, particularly dopamine agonists. If one withdraws the medication, treats the infection, the psychotic symptoms, might likely go away, without any other interventions. In the absence of those circumstances, I think it's harder to say, that this will naturally go away. And those tend to be the patients in which, there can be associated, cognitive impairment or part of their people in the path of Parkinson's disease dementia. I think, in those cases, it's expected that those symptoms are gradually and progressively going to get worse over time. Non-pharmacological interventions can be helpful. I think the avoidance of such medications, the clarification of, and simplification of medication regimens, having a routine for patients, and then obviously physical exercise is well, I think by now, fairly well recognized to probably slow down the progression of Parkinson's disease, at least the motor symptoms. I am not sure we have enough data yet to say that it can slow down, psychiatric symptoms in Parkinson's disease. But it probably goes in the same lines of how physical exercise can be beneficial in cognitive impairment, similar to Alzheimer's disease.
So let's talk about some of the treatments. So our first thing, of course, is we would change environment, remove offending drugs, like dopamine agonists, check for urinary infections and things like that. But let's say you do all that and they're still persisting. What would be your next choice? Would it be PIM or clozapine, quetiapine, none of the above? How would you go about going next? So you've done the workup, you check their urine, you've taken away the dopamine agonists, they're still psychotic.
Yeah, then the next step is in pharmacological intervention, and I think most of movement disorder specialists, will agree with me that we have three options, because all other antipsychotics are contraindicated as they will worsen, the Parkinsonian syndrome. And the three that we have available are quetiapine, pimavanserin, and clozapine. Most people, despite some mixed evidence, will still start with quetiapine because it's readily available and usually easy to obtain, cheap, and it can, cause, some sedation, so if there's a lot of, nighttime agitation, it can help, with sleep. It is not potentially devoid of side effects, including worsening orthostatic hypotension and then daytime sleepiness, and some QT prolongation and other cardiac issues. Pimavanserin has become readily available as well, or easier to get, and it is very well tolerated, and it's once a day, and it can be effective. It has been surprising, again, the tolerability, the few side effects. Although, again, in my opinion, the downside of it is sometimes, for very severe psychotic symptoms, it may not be enough.
Yeah.
And then, when we've tried the above, then we will bring the big guns and we'll do clozapine. We don't typically like to do that if we can avoid it, because of the need for blood monitoring, which nobody likes, to the blood testing, first every week and then every month. But it can be quite effective. It also, may cause some weight gain and other things, but it can be quite effective for psychosis and also for dyskinesias, if, it so happens to be a comorbidity for that particular patient. We rarely would use, other medications like mood stabilizers. If the psychotic symptoms, if it's just visual hallucinations and they're relatively mild, meaning there's perceived insight, there's the occasional little animal that they see, they're not threatening, we may start, rather than with a medication like quetiapine, pimavanserin, or certainly clozapine, we may start with an acetylcholinesterase inhibitor first, and that sometimes can do the trick. And rivastigmine is one that we commonly use in Parkinson's disease that tends to be well tolerated. But if it's more severe, it may not do the trick. What is your approach?
It's funny because I was just remembering from your remarks. I saw a patient yesterday in the clinic with Lewy body dementia who was on risperidone and quetiapine. I'm thinking, how did that? It's a new patient. How did that happen? So I would say that I almost have never used clozapine. So I have quetiapine and some PIM experience. But the quetiapine we're using tends to be, 25 HS, 25 BID, 50 HS. But I understood from the psychopharmacology that to get the antipsychotic effect, you've got to go to 150 milligrams or 50 TID. Are you using those kinds of doses? Because I'm used to using 25 BID, 58 HS, things like that for the sleep. That is, a very good point. And I would say, for very mild, for sleep, for slight delirium in the context, of, especially Parkinson's disease dementia, but they may have some psychotic features, the 25 time or 15, that's typically enough. But when patients have severe Parkinson's disease psychosis, one needs to go into that range, and we'll start low and then slowly titrate it up. Worsening of orthostatic hypotension is a concern when you go into those doses, because, it's also something that tends to happen as Parkinson's disease advances. And they can have, a significant hypotension and even syncope. But it is true that especially rather than visual hallucinations, especially very entrenched delusions, that you have to go a little bit higher up. And it makes sense, from a pharmacological perspective. On pimavanserin, I have found the last 2 times I prescribed it, it took about 4 weeks to 6 weeks to see an effect. And what it did, which was curious, was it lessened the frequency of the psychosis, but what had a bigger effect on the severity. Like, they kind of became aware that they weren't as psychotic. I had one patient who thought she was dead, the Cotard syndrome, as I've been told. And she, a few weeks after starting pimavanserin, she said, I'm still feel like I'm dead, but I know I'm not. And she was more aware, and the family was able to manage that psychosis better. And the other one took, like I said, about 6 weeks to work. Are you finding that pimavanserin takes a while to work, or am I just going about dosing it wrong because I'm using 34 milligrams a day?
Yep. Nope. That's the dose that I would use, starting with 34 a day. I think it takes, about 20 days, to reach a steady state, or around there. And that is true. I think, quetiapine, especially, the sedation effect, happens right away, and that may be beneficial on it itself, but for pimavanserin, I tell people just to hold tight, for the first month and then see, and then not decide, prematurely that it may not be working just because we haven't given it enough time. And then I agree. I think that it lessened the severity of the delusions to an extent that they were manageable, even though they did not disappear. I think that's a good explanation.
One last question is, a lot of these patients have disturbed sleep. Are you using clonazepam, or what are you using to manage the sleep disruption that you see in these patients?
Sleep disorders are almost universal in Parkinson's disease, and they range from a variety of different sleep issues. REM sleep behavior disorder, when people have the dream enactment, we will start, with just melatonin, and that tends to do the trick for the most part, but we may go to clonazepam, and some of these patients may be on clonazepam, usually low doses, less than 1 milligram at bedtime, which, if they do develop cognitive impairment or as the disease advances, may need to revisit as, they may impair their balance and other things. Chronic insomnia, frequent awakenings, and daytime sleepiness, also very common in Parkinson's disease, as well as Parkinson's disease dementia, Parkinson's disease psychosis. I try to start conservative first, again, start with melatonin and sleep hygiene, and then move to something like trazodone, and then if need be, then the clonazepam at low doses. If there's a component of psychosis, or then quetiapine then becomes a little bit of an available option. And we tend to stay away from other medications because of the high likelihood of inducing abnormal behaviors during the night.
In the PD group, that would be more pronounced?
I don't know if it's been formally studied, but certainly from clinical experience, that has been the case. So I've been trying to shy away, from that type of medication class. Never say never, and occasionally there's the patient that is very beneficial. And certainly high doses of zolpidem had been studied in the treatment of dystonia in the context of Parkinson's disease and others. But in general, especially in an elderly group of patients with Parkinson's disease who may have psychosis or cognitive impairment, probably not the greatest idea if it can be managed somehow else. How did you manage sleep disorders in the dementia patients?
The spectrum, Lewy body is, as you would have described it, it's how I would manage the Lewy body patients. But for the patients with other sleep disorders, I would do a sleep study to see if they have, sleep apnea. Nice. I would give them trazodone also. A lot of them are on over-the-counter anticholinergic drugs like the PMs, the diphenhydramines, the amitriptylines, and I try to get those off. And I also use mirtazapine from time to time as well. So we have a few options. Interestingly enough, there is two drugs that I love, which is Ramelteon and Sorexabant. Sorexabant is actually approved for sleep-related disturbance in Alzheimer's disease. And neither drug, Ramelteon or Sorexabant, are used commonly because they're just hard to get approved. So it is what it is.
Well, good to know. You've given me some ideas.
Thank you. Dr. San Luciano, thank you very much.
Thank you.
Thank you very much to Drs. Sabbagh and San Luciano, and thanks to you for joining us. As a reminder, to view the full program, Diagnosis and Management of Parkinson's Disease Dementia, and to learn more about this topic from Clinical Care Options, please click on the link in the show notes. As always, thanks for listening.